Other disorders of the liver. Cirrhosis. Result of chronic scarring of liver tissue turning it into nodules. May be caused by excessive alcohol ingestion over a long period of time, hemochromatosis, or as a complication of hepatitis. Tumors. Hepatocellular carcinoma or hepatoma, primary cancer of the liver. Metastatic liver tumors arise from other cancerous tissue where the primary site was of lung, pancreas, gastrointestinal tract, or ovary origin. Reye syndrome. The cause is unknown, but the symptoms include encephalopathy, neurologic abnormalities including seizures or coma, and abnormal liver function tests due to hepatic destruction. It occurs mainly in children, usually after a viral infection like varicella or influenza and aspirin therapy. Drug-related disorders. Drugs including phenothiazines, antibiotics, anti-neoplastic drugs, and anti-inflammatory drugs such as acetaminophen may cause liver damage. Acute and chronic hepatitis. Serum enzymes used to assess liver function. Markers for hepatocellular necrosis, ALT, most specific for hepatocyte injury. AST, less specific than ALT, significant presence in other tissues. LD, least specific, significant presence in other tissues. Markers that reflect cholestasis include alkaline phosphatase and gamma-glutamyl transferase. Other tests to assess liver disorders are total bilirubin, direct bilirubin, which is conjugated, and indirect bilirubin, which is unconjugated. Additionally, albumin, ammonia, and alpha-fetoprotein, or AFP, are also assessed. The test methodology for bilirubin involves a few key methods. The Jędrusik-Grof total bilirubin test is one method, where bilirubin reacts with sodium acetate, caffeine sodium benzoate, and diazotized sulfonylic acid to form a purple azobilirubin. This then reacts with alkaline tartrate to form a green-blue azobilirubin, measured at 600 nanometers. For newborns, the direct spectrophotometric method is used. Here, the bilirubin concentration is read directly by spectrophotometry, and the concentration is proportional to the absorbance at 455 nanometers. It's important to note sources of error, such as hemolysis and lipemia, and to avoid exposure to sunlight and fluorescent lighting. The reference ranges for infants are as follows. Total bilirubin should be between 2 to 6 milligrams per deciliter for a full-term infant on the first day of life. The test methodology for urobilinogen varies depending on the sample type. In serum, for adults, the total bilirubin should be between 0.2 to 1 milligram per deciliter. Indirect bilirubin ranges from 0.2 to 0.8 milligrams per deciliter, and direct bilirubin ranges from 0 to 0.2 milligrams per deciliter. In feces, urobilinogen is a collective term for stercobilinogen, mesobilinogen, and urobilinogen. For urine, the urobilinogen assay is used. However, sources of error include oxidation if the urine is allowed to stand, and reactions with other compounds such as porphobilinogen. The reaction of urobilinogen with p-dimethyl aminobenzaldehyde forms a red-colored complex. In cases of posthepatic obstruction, urobilinogen formation is decreased due to impaired bilirubin excretion into the intestines. This can be evidenced by a clay-colored stool in partial biliary obstruction or a chalky white stool in complete biliary obstruction. Increased urine urobilinogen is associated with hemolytic disease and hepatocellular disease, such as hepatitis. The reference range for urine urobilinogen is 0.1 to 1 Ehrlich units per 2 hours.